All right, hello everyone, and welcome to our webinar, The Role of a Host Response Test Septicyte Rapid to Improve Sepsis Bundle Compliance and Address Diagnostic Uncertainty. Sepsis Alliance gratefully acknowledges the support provided for this webinar by Immunexpress. The content in today's presentation was determined by our sponsor. And before we get started, I'll just quickly speak to Sepsis Alliance's mission. Sepsis Alliance develops sepsis awareness and education programs. Our mission is to save lives and reduce suffering by improving sepsis awareness and care both for the public and for healthcare professionals. And just as a reminder, the information presented today is intended for educational purposes only. So with that, I'm so excited to introduce our presenters today. Dr. Roy Davis, who's Chief Medical Officer at Immunexpress, will start with an introduction to the topic, and we'll then turn it over to Dr. Russell Miller, who's the Medical Director of Critical Care at FirstHealth of the Carolinas. So with that, Dr. Davis, I will turn things over to you.
Thank you, Hannah. I'd like to thank everyone for taking time out of their busy days to join us today. What I'd like to do is introduce you to Septicyte Rapid, a host response test for the early identification and appropriate intervention for suspected sepsis. Next slide, please. I'd like to go over Septicyte technology, discuss its clearance and its validation for host response tests for sepsis, and then discuss some of the clinical values of Septicyte Rapid, including its turnaround time, its diagnostic process, differentiation of sepsis from SIRS, its relationship to the other tests that we presently use, and then alignment with the guidelines that are published for management of sepsis by Surviving Sepsis Campaign, the CDC guidelines, and CMS's SEP1 value-based processing process. Also discuss Septicyte in various patient populations, and then the actual running of Septicyte Rapid on the IDILA platform. Next slide, please. Septicyte Rapid is a host response technology. It measures mRNA in white blood cells. It quantifies the expression of two white cell genes, PLAC8 and PLA2G7. It's specific to infection and systemic inflammation, not localized infection, and is independent of the type of pathogen causing sepsis, whether that be bacterial, gram-positive, gram-negative, viral, or fungal, and it's not reliant on finding the pathogen within the blood sample. It measures the test in approximately 60 minutes and translates this into a clinical score from 0 to 15, reports the likelihood of sepsis, it's independent of the severity of the disease, and gives an actionable result with that score in 100% of suspected sepsis patients. Next slide, please. Septicyte Rapid has been cleared by the FDA as a host response test specifically for sepsis. It's a gene expression assay using PCR, and it measures the ratio of mRNA of two host response genes, PLA8 and PLA2G7, one of which is upregulated, the other is downregulated in the presence of systemic infection and systemic inflammation. It differentiates sepsis from SIRS, reporting this as a clinical risk score of 0 to 15, falling into 4 discrete interpretation bands. It gives actionable results in approximately 60 minutes and reports the likelihood of sepsis, and again, it's independent of disease severity or the causative pathogen. The test is run on the IDILA platform. It uses a cartridge-based process and takes about 2 minutes of handling with regards to putting the blood into the cartridge. The cartridge is placed into the instrument, and the result is reported out in 1 hour. Next slide, please. The validation process of sepsis is difficult from the standpoint of we do not have a gold standard for the diagnosis of sepsis. So from a validation standpoint, Septicyte Rapid was validated using a retrospective physician diagnostic panel of 3 clinical experts who reviewed the charts on these patients and decided if the patient had sepsis or SIRS. This was then evaluated from the standpoint of ROC AUC curves. And in this graph, you can see there are 3 AUC curves reported because we used a unanimous, consensus, and forced diagnostic process. Approximately 70% of the cases were unanimous in their diagnostic process, leaving 30% where we had consensus of 2 people, and then we forced the diagnosis when all 3 disagreed. So there are 3 ROC AUC curves, giving a ROC AUC of differentiating sepsis from SIRS of 0.85. The score is reported, as I said, is from 0 to 15 and broken up into 4 bands. Band 1 has a low risk of sepsis with a sensitivity of 94% and a negative predictive value of 0.91 to rule out sepsis. Band 4, patients who fall in this band between 7 and 15 score have a high risk of sepsis with a high specificity of 90% and a positive predictive value of 0.81. From the standpoint of evaluating these scores, likelihood ratios are appropriate to be used, and band 1 has a likelihood ratio of 0.18, band 2 0.3, putting these two groups into a low risk of sepsis. And in band 4, the likelihood ratio ranges greater than 6, giving you a high probability of sepsis within there. It accounts for 80% of the patients fall into bands 1, 2, and 4, with band 3 being a small area of patients where ancillary tests can be used to help drive that diagnostic process one way or the other. Next slide, please. As part of this validation process, we evaluated 14 other clinical variables that are frequently used to evaluate the diagnosis of sepsis. We compared these with the Septiscore and without Septiscore. This graph shows a breakdown of these 14 variables with lactate as the first one, which is part of the sepsis bundle, which, as you know, is not really a sepsis diagnostic, but a perfusion diagnostic, but is part of the sepsis bundle and has an AUC of differentiating sepsis from SIRS of about 0.54. When we add lactate to the other 14 clinical variables, excluding Septicyte Rapid, we get some improvement in the diagnostic process, and these are what we use on a daily basis to assess whether we have a patient with sepsis or not. This AUC runs from about 0.6 to 0.75. We add PCT, which, as you know, is a diagnostic from a standpoint of bacterial infection, not specifically sepsis, but is helpful in differentiating viral from bacterial disease. And PCT alone has an AUC of differentiating sepsis from SIRS of 0.77. Add those multiple clinical variables to PCT, and we get some improvement in the diagnostic process. And this is where we stand today with regards to our diagnosis of sepsis with an AUC of about 0.8. Septicyte Rapid alone, using the Septiscore, has an AUC of 0.84. And if you add that to the other clinical variables, we get a slight improvement, helping us, especially with band 3, to make a diagnosis of these patients. So Septicyte score alone is superior to all the other tests that we have and can be used in combination to improve that clinical diagnosis. Next slide, please. As you know, Surviving Sepsis Campaign has, over the last 10 years, published management guidelines on an intermittent basis with regards to determining the management of sepsis and severe sepsis and septic shock. Recently, in November of 2021, they published their latest management guidelines, and we see Septicyte Rapid aligning with these guidelines from the standpoint of they recommend determining whether this is infectious or non-infectious systemic infection, and Septicyte Rapid does exactly that with a 1-hour turnaround time, helps in that diagnosis process, and helps initiate the 3-hour bundle and confirm the 1-hour bundle recommended for the management of sepsis. Surviving Sepsis Campaign has also pointed out that the majority of our sepsis screens that we presently use are very sensitive, but not very specific, and Septicyte Rapid has high specificity, improving that probability from a diagnostic standpoint. Recently, the CDC recommended guidelines and core elements that should be included in a sepsis management program, and Septicyte Rapid can help with that process from the standpoint of Septicyte Rapid facilitates early recognition. Septicyte Rapid also has a unique ICD-10 code, which allows you to accurately document sepsis, improving epidemiological evaluation of the frequency and occurrence of sepsis within your institution. Also, Septicyte Rapid educational processes. We as a group supported multiple webinars and podcasts and hospital presentations to improve that educational process. CMS, as you know, has over the last 10 years managed a reporting process for the sepsis bundle compliance, which has been voluntary. As of 2026, they're adding sepsis bundle measurements to the hospital-based value proposition process, where financial incentives will be linked to performance with regards to sepsis care. We feel that Septicyte Rapid will help improve that compliance and improve both the sepsis compliance to bundle compliance and also one's ability to improve a reporting process to hospital-based value-based programs. Next slide, please. Over the last 3 years, multiple publications and posters have been presented with regards to patient populations in which Septicyte Rapid has been used. For example, there's been a number of studies in Europe, which we've been in use over the last 2 years with regards to abdominal surgical patients who are being managed post-surgery and who have a risk of possible infection, and have shown clearly that Septicyte Rapid helps identify these patients who are developing sepsis post-surgery early and with accuracy. Oncology and immunocompromised patients are two groups that obviously stand out with regards to the difficulty in making the diagnosis of sepsis. And 2 posters and a paper have been presented that show clear differentiation of sepsis from SIRS in patients who are immunocompromised or on anti-neoplastic medications with cancer patients. Also had a paper presented on severe burn patients who are being monitored post-burns for the development of secondary infection and sepsis, showing good correlation with regards to early recognition of those patients who have secondary sepsis related to their burns. One of the frequent complications we have with regards to the diagnosis of urosepsis is that patients are admitted frequently with UTIs and side effects that may be related to sepsis, and differentiating whether they have urosepsis versus a UTI with other complications. Septicyte Rapid has clearly differentiated this group into a group of patients who have urosepsis versus UTI. Pulmonary sepsis is one of the major problems we face frequently as patients admitted with chronic obstructive pulmonary disease, secondary pneumonia. Difficult to diagnose these patients with regards to whether they have primary pulmonary infection or secondary sepsis related. Paper published in Europe on this showed clear differentiation with regards to those patients that have isolated pulmonary infection or secondary sepsis. Obviously, during our recent pandemic process, we've had a number of evaluations with regards to COVID-19, and Septicyte Rapid has been shown to clearly differentiate those patients with severe COVID infection, probable viral sepsis, from those patients with mild or moderate COVID disease. We've also had a preliminary evaluation of pediatric patients and recently submitted to the FDA a 510(k) application for clearance for pediatric patients. And so hopefully we'll get that in the near future and enable us to differentiate those patients who in the 1 month to 18 years of age that have developed sepsis. So there's a growing evidence of a performance of Septicyte Rapid in multiple patient populations, enabling this diagnosis to be more clearly clarified with regards to the presence or absence of systemic inflammatory response due to sepsis. Next slide, please. Septicyte Rapid workflow from the standpoint of how it's used. The sample is collected in either packaging tube, next slide, sorry, and is RNA stabilized, or we recently received clearance from the FDA to use EDTA blood sample, which makes that easy from the standpoint of no extra blood is needed to be collected. Sample extraction is carried out by the cartridge-based process with total nucleic acid purification. Next, please. And the quantitative and process of replication is fully automated and carried out in the cartridge once placed in the instrument. A report is generated within 1 hour, and one of the other advantages is that the storage of this process requires only room air, not a cold chain process. Next slide, please. As I mentioned earlier, Septicyte Rapid is reported as a score of 0 to 15 with 4 bands. Band 1 having a low risk, band 4 having a high risk of sepsis. Examples here of reporting process is that for band 1, it's reported as a low risk of sepsis with a score of 4.9 in this case. Band 1, low probability of sepsis. There's also innate control, allowing the validation of the test to be validated and passing the control process. High risk of sepsis is reported in band 4, with a high risk of sepsis with a percentage probability of sepsis reported, again, validated from a sample processing control and validated with the innate controls within the cartridge. Next slide, please. This is just a slide that covers some of the publications that have been presented and reported, plus some posters that have been presented recently, including the validation of EDTA, which I think is a major step forward with regards to not requiring a specific packaging tube collection, which is expensive, requires a separate draw process and ordering process. So I think that covers, from my standpoint, the introduction, and I'd like to turn it over to Dr. Miller to present some clinical applications through case studies of the use of Septicyte Rapid. Russ?
Thank you, Roy. This is an opportunity, I hope, to share the community hospital experience, or our community hospital experience thus far with Septicyte Rapid. The test itself seems to have, at least for some time, be building momentum, and the opportunity to use this clinically, I think, is really important. Hannah, next. There are three main takeaways, and these will correlate with cases. The first is that Septicyte Rapid may encourage more rapid identification of other etiologies of illness than sepsis, for example, that it also might influence the initial consideration, diagnostic consideration altogether in critically ill patients. And finally, that it might provide additional reassurance, which may seem unnecessary in some cases, but if it does influence the timing of therapy and even mitigate progression of more severe disease, would bear fruit, I think, for us in a clinical purpose. Next. So my first case is an 82-year-old gentleman with lots of heart and lung issues who presented with altermentation and 3 days of weakness. By vitals, he was afebrile, hypertensive, heart rate was elevated, respiratory rate was not elevated, lactate, however, was elevated and improved over the course of a few hours with gentle fluids. In the meantime, several things became available clinically to us, not the least of which was his white count, which also is not markedly elevated, a troponin that with some elevation. This is not a high sensitivity. This is a regular troponin, I, and then a BNP of 600. Next slide. He underwent, by virtue of coming through the emergency department and having what seemed like an unclear etiology of his illness, a chest CT, which was described as showing some dependent consolidation, especially on the right side, as well as debris in the right main stem. Next slide. Obviously, during all of this time, his Septicyte Rapid also came back approximately 85 minutes after it was ordered. Now, again, that allows for the 60-minute runtime, as well as a few minutes, especially early on in our experience, in getting the sample and getting it to the lab and getting the result. This was a band 2 result, which yielded a sepsis probability somewhere in the low 20s. Next slide. And as Dr. Davis has previously demonstrated at least some of this in terms of the likelihood ratios, you do see, and I wanted to add for emphasis here, the likelihood ratio for band 2 is also low. 0.4 is a not astoundingly low, but a very low in a Bayesian world likelihood ratio. So that is good. Band 3, as he alluded to, is a little bit in that nebulous zone where the likelihood ratio sits right around 1. In the bottom left, you see some of the initial data from the Septicyte Rapid, where the relative probability of sepsis increases not linearly with increasing score and thus increasing band, with good discrimination in the bottom right between sepsis and SIRS. Next slide. The patient, by virtue, again, of coming into an emergency department and having the initial read of some dependent consolidation in the right lung, was placed on antibiotics. He subsequently seized a couple of times in the emergency department, became progressively hypoxic, and therefore underwent bronchoscopy with secretion removal and fairly prompt improvement in oxygenation to follow. Next slide. Obviously, over time, we got additional data back, but in the meantime, cultures, notably from the bronchoscopy, were negative. And then, as I said, blood and urine eventually came back and confirmed negative. Viral swab was negative as well. So the question might be, in such a case, what do you do? Now, if you remember, he had an elevated heart rate, but a white count that was normal, was afebrile, and did not have an elevated respiratory rate. So by 1992 criteria, this doesn't necessarily feel like sepsis. By 2001 and et cetera criteria, it doesn't really feel like sepsis, but you have this abnormal imaging finding that makes you wonder, is this an 82-year-old gentleman with pneumonia, for example? And it's presenting more subtly. Next slide. In light of the band 2 result, I wanted to highlight, and this is a slide I will keep pinging back to on purpose, but that practically speaking, band 2 is associated with a relatively low, we said about 20%, low 20% occurrence of sepsis. And I think, actionable piece of that or component for us clinically is to pay real close attention to other etiologies and continue to look. Now, it turns out, of course, that this gentleman then seized in the emergency department. So was the primary problem a neurologic problem with a secondary aspiration, which may not have been infectious at all, and thus not requiring antibiotics in the absence of other compelling criteria? And so, in fact, the suggestion would be to reevaluate the need for antibiotics in the next 48 to 72 hours. Also, some of you may be wondering, well, gosh, I wouldn't have called that sepsis in the first place. And I think that's entirely reasonable. This result doesn't force you to consider otherwise, but it does highlight the fact that this patient does potentially have an infection, and it's worth investigating both that and the other etiologies simultaneously. Next slide. So a second case to try to drive home maybe some of the clinical utility here. A 60-year-old gentleman with hypertension, hadn't seen a doctor in years. I don't know if you have such patients, but I'm guessing you do. With abdominal, flank, and back pain. Had some more recent constipation, nausea, but no dysuria. He, again, was afebrile, again, hypertensive. I'm not entirely sure why this was a recurring theme, but did have an elevated heart rate again, and also had a respiratory rate of 16, that is to say, less than 20. And lactate was normal in this case, as well as his white count. His urinalysis had a few things on it that raised potential suspicion, although trace is a notably small quantity. It is uncommon in a male, nonetheless, and there were no squamous cells to sort of attribute potentially a contaminated sample to. And so there was, on next slide, at least some consideration for the possibility of infection. And yet, his sepsis score and his associated band of sepsis risk was band 1, providing additional confidence, I think, to the clinical team, and next slide, that in fact, this was likely not sepsis, that there was some other etiology. And it turns out he walked in having not seen a doctor for a number of years, and in fact had a primary prostatic malignancy. And that was causing many of the signs and symptoms he had, including the retention of urine leading to elevated heart rate. The recommendation or thought behind what to do with such a result in general, of course, is to acknowledge that there's a low risk of actual sepsis in such patients with a band 1 result, and arguably to ensure that the idea of sepsis is not even entertained into the record, because that wasn't likely, but also not what in the end, should you be looking at the discharge summary, for example, not in the end what actually caused him to present to the hospital. And so it's a good example. And I don't know about your hospital, but my hospital, and especially my emergency room, is so tuned to the concept and need to call sepsis as early and as much as reasonably possible, that such a test as this that provides a reassuring negative result actually has the opportunity, which we are investigating, but the opportunity to bend that curve and bend the overcall of infectious SIRS or sepsis as an etiology for patients. Next slide. The differential ultimately included a lot of things in this patient. And so because of that, despite all of what I just said, he got the sepsis bolus. So that, again, this is an example where arguably the presence of the test could have and should have influenced the likelihood of getting a fluid bolus. On the other hand, he was weak and tachycardic, and it isn't unreasonable to give some fluid to such a patient in the absence of complications with doing so, such as pulmonary edema or otherwise. His imaging indeed confirmed some subcarinal lymphadenopathy, which was obviously worrisome, as well as an enlarged prostate. And it turns out not only did he have the prostate cancer as a new diagnosis following discharge and upon presentation to an outside urologist, but also he did have a gastric ulcer. And that probably contributed to his initial presentation, but was, of course, as is the case with most ulcers, not infectious in the absence of perforation. So, so again, a case where the test, I think, yields some benefit in helping to hammer away the diagnosis of sepsis when you might have looked at some subcarinal adenopathy and a little bit abnormal urinalysis and still wondered whether this was, in fact, evolving sepsis at least. Next slide. Also important is the fact that because of the Septicyte result, according to the emergency room physician, and the competing alternate etiologies discovered, he did not ever get antibiotics, which I consider a win from an antimicrobial stewardship standpoint, but also because it is useful to acknowledge the times when we don't have to follow the sepsis bundle and can turn away from it appropriately. Next slide. Finally, I have a 35-year-old female who comes in with hypertension, tobacco abuse, had sores in her mouth and throat, crusting of her eyelids, some difficulty swallowing, and a very mild, nonspecific rash, but all of which had progressed over a day or so. She again was hypertensive, afebrile, again tachycardic, again respiratory rate 18. So by 1992 and most subsequent criteria until a few years ago, you would have said not sepsis. Q-SOFA wouldn't have helped you here either. Fermentation was normal. White count was normal. Lactate was mildly elevated. That would hit the old categorization, the clinical categorization of severe sepsis, if you thought sepsis was present. But again, what sepsis criteria does she meet? Next slide. There was, in fact, initial concern for an allergic reaction, although it was subsequently identified that she had been on no recent new medications. Again, she wasn't really being followed closely as a 35-year-old female with hypertension on what's supposed to be a single medication outpatient, and had in particular not received any recent antibiotics. Next slide. Her Septicyte result then was a bit surprising at band 4 and yielded appropriately a little more concern from the emergency room staff upon identifying that. Next slide. So again, here we have a band 4 result. Now the suggestion here would be this is somebody who is going to meet criteria. And again, in the new world of diagnostics, the presence of a band 4 sepsis result, has an ICD-10 code associated with it by which you could identify this as sepsis. And whether you and I feel comfortable in the absence of such a test identifying it is going to come up to likely our own face-to-face observation, because things were happening with this patient. Next slide. It turns out she did get a fluid bolus and prompt antibiotics because there was just a sense about her that something might be more going on than just an allergic reaction. And in fact, within 4 hours, she was febrile, had a desquamative rash of her back and upper extremities, and erythema in her distal extremities as well. And she got a prompt skin biopsy, but also a prompt call to a tertiary care center, burn center, actually, because it was fairly obvious to astute clinicians that this was evolving some form of, whether it's Stevens-Johnson's or toxic epidermal necrolysis, but in fact, it's an overlap syndrome because of the percent of her body that became affected. Next slide. Actually, go back one, sorry. I would like to point out that I am aware that, the use of antibiotics for preventive progression to infection in such patients, as Stevens-Johnson's, is not solidified. But at this point, you now have a febrile tachycardic patient who, in fact, by this point in time, had a respiratory rate in the mid to upper 20s and was looking toxic. And upon that basis, again, appropriate to consider antibiotics. When 4 hours prior, in the absence of that test, it was unknown what was going on with her. And in fact, she didn't appear terribly sick at that point. That is to say, arguably, that the Septicyte helped lead the clinician to recognition of what was to come and allowed the prompt antibiotics and fluid bolus to occur. So next slide. These are three cases. The first one, I think you identify, I hope, as encouraging more rapid identification of alternate etiologies. So you got a band 2 result of, it's possible it's sepsis, but are there other things that are more explicable in the context of the current presentation? The next was a band 1 result. That is to say, it should have and did influence the consideration of sepsis at all in that patient. And then band 4, while again, by the time the patient was toxic in front of you, you didn't need anything else probably to identify that this was a sick patient. The specific fact that the test resulted, and it was about 80 to 85 minutes in this case, again, early in our experience with the test, it identified that patient as being particularly sick and allowed for initiation of therapy in accordance with the sepsis bundles that prevented, arguably, progression to more severe disease. And in fact, the patient did end up doing well, albeit with 20 to 30% skin involvement from the SCSS-TEN of, as yet, unclear etiology. That, I think, is the summary of my presentation as well. I appreciate the opportunity to speak, and I will turn it back over to Hannah.
Thank you so much, Dr. Miller, and thank you to Dr. Davis as well. Great presentation here. So folks, we do have quite a bit of time for questions, so please feel free to be typing any questions you have for our presenters into the Q&A box on your webinar dashboard. And again, we'll try to get through as many as we have time for here. So first question, I believe, is going to be for Dr. Davis. So Roy, what is the hit rate for Septicyte and clinical variables without the PCT?
So with regards to the clinical variables that we used, excluding PCT, which in the United States a lot of people do not use, the clinical hit rate remains still very high at about 0.84 if you include the other variables. PCT helps obviously a lot with regards to differentiating viral sepsis from bacterial sepsis. And COVID, I think, has taught us a lesson with regards to those severely ill COVID patients who had probably viral sepsis. And we've seen some more evidence with regards to flu A and B that Septicyte Rapid can clearly differentiate those two. So I think PCT has a place, but not necessarily from the standpoint of diagnosing sepsis, but from a bacterial versus viral, and then also antibiotic decreasing dosage and or timing post initial initiation of antibiotics.
Great. Okay, thank you. This next one I will direct toward you, Dr. Miller. In your organization, is this only run in the ED or is this for inpatient also?
As we are relatively new to the use of this test, anyone would be, we have mostly restricted it in our initial run to the emergency department. It is also true that as you may or may not be aware, FDA approval was sought and pursued for critically ill patients, particularly in the context of the emergency department. Having said that, it is entirely expected that over time it will be part of our sepsis bundle, and as such, it would get run whenever new sepsis is found or considered.
Yeah, I think that if I can add to that, with regards to the validation process, 67% of patients came from the emergency department. The remaining 25-30% came from the floors or post-surgical. So that it was used for hospital-based, hospital-acquired infections on the floor or progression of disease post-admission to the floor from the ED.
Okay, fantastic. Thank you both. Next question here. Has Septicyte Rapid shown higher accuracy in any one of the patient populations that you mentioned, Dr. Davis, that were clinically evaluated versus the others?
From a breakdown standpoint, I don't think it showed any difference with regards to higher accuracy, although 80% of patients in band 4 had a positive blood culture. So it's being used, for example, as a study being looked at with regards to drawing the sample. If it's band 4, then using T2, for example, to see if there's actual bacterial identification, prompting the fact that it will have probably a higher incidence of positive blood cultures.
Fantastic. Okay, thank you. Next one, we'll start with you, Dr. Miller. How can we plan to incorporate Septicyte Rapid into our organization's sepsis bundle workup and educate clinicians on how to use the scores?
Yeah, I think to some extent that remains an open question with any new diagnostic, right? Having said that, the most straightforward way to effect change, of course, is to standardize, and the standardization of that is to include it in your initial order set. And so we have it included in one of our initial order sets for patients who we are considering at least ill enough to warrant potentially drawing cultures and other things. So the short answer is the only way to do effective change like this probably is to standardize it, and thus it needs to land in an order set. And in terms of the education, I think some of that comes from data that exists, but as you and I both know, as all of us know, the ultimate way to achieve that is to be sure to provide an answer to why. What is it about this test, and why is it something that we should be using, and why is it something that makes a difference? And that's part of what I attempted to do in my presentation, was to answer that question of why. If you have the magic of how to encourage a group of 20 to 100 providers how to all get on board at one time and understand, then I would love to chat with you. Having said that, again, order sets provide a standard and way that provides a simple path, perhaps more than anything, to ensuring that the test is available, and then reminding people to, with any new test like this, to look upon it and to consider it.
If I could
Fantastic.
add to that,
Yep.
I think that we have a couple of institutions that are validating the test within their institution from the standpoint of whether they should incorporate it or not. And a lot of places have an early triage process in the emergency room, for example, where the nurse or somebody may assess a patient as possible sepsis. That drives them to initiation of a bundle. And these two hospitals are incorporating that into their bundle to see if that impacts their early initiation of antibiotics in appropriate cases, sepsis compliance process, and appropriate holding of antibiotics, and evaluating the patient further, as Russ showed in a couple of patients that don't have sepsis and need further evaluation from the standpoint of driving diagnostic stewardship as well as antibiotic stewardship.
Fantastic. Thanks very much. It looks like we've got one more question, folks. If you do have any lingering questions, please feel free to type them into the Q&A box. We'll get through a couple more here. So, Steve, I see your question, so we'll get to that. Next question here, is there concern for delaying further evaluation or withholding antibiotics if sepsis suspicion is low and septic score is low?
I will attempt to answer that. I'm not entirely sure I know how to answer that, but I guess what I would say is that, you know, the goal here, of course, is to both give aggressive treatment whenever possible, but also stop giving unnecessary treatment. And while I would argue that what all of us seek in this is some definitive proof of when a patient has sepsis, we actually benefit equally well from knowing when a patient doesn't likely have sepsis. So I'm not sure that's an answer to your question, but at least that's my stab at that. And perhaps to some extent, it can't be known until you incorporate it into your own system and sort of get some experience with it, how it affects you locally.
Got it. Okay. And the last question here, how long did adoption take for your organization, Dr. Miller?
Well, we, like other places, have many competing interests in our lab, and any lab, you know, and budget constraints and all kinds of things, you know, come into play when you try to introduce a new test and a new process. We had a new director of microbiology come in the middle of our attempted rollout. So it took us, clearly did take us about a year or so. But again, it was influenced by a number of factors that if there had been more stability from that standpoint, probably could have been reduced to months rather than a year to a year and a half. In terms of the education and that part of the process, honestly, that didn't take as long. And then we'll follow our data and see to what extent we have proper uptake and utility of the test, as well as get some clinician input on the value and ways in which we could modify its inclusion in our order set to improve the clinical utility for bedside staff.
Got it. Okay. And I did see a last minute question come in here, so we'll take that as well. Can you discuss how exactly it's measured? Is this via blood and PCR testing?
Yes, it's a PCR test that measures the changes in up and down regulation of two genes. One gene is upregulated, the other is downregulated in the presence of systemic infectious disease response. And that ratio is then used to generate the score. The higher the ratio, the higher the score.
Got it. Okay, thank you so much. And I think that is a great place to wrap up. So Dr. Davis, Dr. Miller, thank you so much for your presentations and for your time answering those questions. Certainly appreciate you being here. Thank you very much.
Thank you.